So just picking up right where we left off, we talked last time about group 3 mood stabilizers. So now we're moving on to group 4 opioid analgesics. And so basically, an opioid analgesic is a drug that is able to induce sleep. Refer to these as narcotics, and analgesic is pain relieving. They have pain relieving properties, and so typically people use the term opioid and opiate interchangeably, but they actually do mean two different things. So an opiate is a natural opioid, and a natural opioid examples are heroin, morphine, and codeine. Opioids refers to all natural, semi-synthetic, and synthetic opioids. So all opiates are opioids, but not all opioids are opiates. And so it's definitely a different, use of the term. And so the opiates, these are derived from opium, which is an extract from the opium poppy seeds. And so these, of course, are those natural, examples, which is, for example, codeine, which used to be used as a cough medicine or cough suppressant, as well as used for pain relief. And it would be something that you could even give children. It was something that was readily available. And then, of course, morphine is an example. It's a good pain reliever. It's a powerful pain reliever. And, of course, we have heroin derived from that. Heroin is a faster acting version of morphine, which is why it has more addiction potential. Now, opium, these are some derivatives and some neuropeptides. These are endogenous opioid neuropeptides, which means that we have these naturally in our brains. And so if we, for example, get hurt or something like that, we will see endorphins as one example, kind of rushing the brain to relieve the pain. And so what opioids do is essentially mimic that process, which we'll talk about here in a minute. So opioids, again, these are those compounds that's binding to our natural receptors in our brains that are sensitive to morphine. And these are the two sort of natural sources. We have the opium, which has been used for thousands of years by humans, and so it gives a sense of euphoria. It has been used for as an analgesic. It's been used for sleep. It's been used for things like coughing and diarrhea. It does slow the digestive system down, and so people who use opioids extensively actually experience constipation issues. So as you can imagine, it would be a good treatment for diarrhea. In the brain, of course, we do have peptides in the body that are similar to opioids. We call these kind of collectively as endorphins, as I've referenced before, also known as endogenous morphines, and endogenous meaning coming from within, something that we naturally produce. Now, we can find these endorphins and receptors all throughout the brain as well as the spinal cord. And so, this is a particular hormone that is specific to help when we are feeling when we're in pain and we experience an injury, as well as pleasure. So this is something that's natural. We have three classes of endorphins: the endomorphins, and enkephalins, which refers to the head, and dynorphins. And of course, we do have these receptors that are specific to different substances. And so we have the mu, kappa, and delta receptor types for each of these. Now, looking at the different kinds and derivations of, whether it's made in lab or whether it's made for medication, we have, sort of natural or morphine. It would be an example of a natural substance that mimics endorphins, but also synthetic forms. So heroin, oxymorphone, methadone, oxycodone, fentanyl, especially is a potent one, mimics endorphins, and it does so in a way that is much more effective, and it is more powerful than our natural endorphins. And so we see that a lot of these synthetic opioids tend to be prescribed for pain management. And of course, we know that there is an opioid epidemic. And so obviously, if you take these substances for pain management, you actually now have to go on a pain management plan and make sure that you are taking them safely. All opioids have the potential for addiction and abuse, and we see that abuse of prescription opioids is much more common. However, we can see that with the right kind of plan and with a plan to, in most cases, take people off of the medication eventually. So if you get prescribed for an injury or for surgery, the idea is to eventually get off of that medication. Then most people are successful. There are, of course, the select few who do abuse the drug. Now, how this works in the brain, morphine, for example, most closely mimics endomorphins, and they're binding to that mu receptor. Synthetic opioids also affect the mu receptors as well, and heroin is synthesized from morphine. It is more it works faster and is more efficient because it's more fat soluble, and it can penetrate that blood-brain barrier faster than morphine. So if you had a person who was using and they had a choice between heroin and morphine, they likely would pick heroin over morphine because it works so quickly. And so some of the spaces that we see binding to opiates binding to those opioid receptors. We see the locus coeruleus, for example. We also see the periaqueductal gray matter area, which you can see right here. That being an area that we see as being activated during the use of opioids. Now, as you may be aware, there are definitely medications or synthetic opioids that are prescribed for pain management. We've already mentioned those before. Oxymorphone, fentanyl, for example, oxycodone, all being examples of those. Now, if you have a person who is experiencing an overdose of, they've taken too much of a prescription, or they've taken, for example, a fentanyl overdose or something like that, there are mechanisms that we can use that will essentially block any more of that opioid from binding to those receptors, and we use we call competitive inhibitors. They're essentially blocking the ability for those opioids to bind to receptors. It's basically getting right in the way, and serving as an antagonist. And so naloxone is an example of one of this. Is also referred to as Narcan. And so basically what you do is if a person is experiencing an overdose, you would then, there's two versions of it. You can, and EMS workers a lot of times carry them, and policemen often carry them, especially in those sort of epidemic areas. Basically, the one version is a nasal, intranasal spray. So if a person is experiencing an overdose, you would then administer that, and if they're still demonstrating symptoms over a short period of time, you can then give them another dose. And then there's another kind of almost like an EpiPen version of it, where you would then administer it through a needle. And so it actually works very quickly. If it's going to work, it's going to work really, really quickly to reverse essentially that overdose. Now, you can't just overdose and then administer this and be right and fine and everything's great. It is not a pleasant experience to have Narcan or naloxone after the overdose. There's a lot of side effects, and it is just a very unpleasant experience because it basically throws you into sort of immediate, almost like a withdrawal, because it's blocking all of this activation. And also you would then need to take the person to the hospital so that they can then be observed, because that's something that you definitely don't want to, that you need somebody to recover from. Now, if you use opioids repeatedly, of course, you can develop a tolerance rather quickly, and it doesn't take very long. Just within about a few weeks, you might see that a dose might need to be increased tenfold in order to get the same effect. And so if you are taking it because you want to relieve pain, and you keep upping the dose, then you're going to continue to need to increase the dose, developing tolerance in order to get the same effect. Now, if you, obviously, if you're going through withdrawal, then that can have a sort of reverse effect. where you would then experience some like of the reverse of the things that you experience while on the medication. So looking at the physiological changes, so opioid use produces relaxation, sleep, some euphoria. It can also cause constipation. But if used too heavily, if you and have too much, obviously it can cause problems like respiratory depression, because it is basically depressing all of the systems to help you to continue to breathe. It can decrease your blood pressure in a dangerous way. You can also see your pupils constrict, and then also it can actually give you symptoms of hypothermia, and mess with your regulation of your body temperature. Now, so if you withdraw from opioids, then you can actually see pretty much a complete reversal of all of the things in a very bad way. So you can be really on edge. You can have issues not being able to sleep. You might go into more of a depression, and because constipation is one of the effects that you see with taking the medication, obviously your digestive system will stop slowing down and sometimes get really serious, very painful cramps and diarrhea. So again, just being really careful about, withdrawal of different substances. So the last kind of group that we're going to talk about is the psychotropics, and there's a lot here. There's a lot of information on these slides, so I do highly suggest that you kind of pause and go, because I'm not going to read through everything. But, just to kind of, just generally speaking, any stimulant that you take is going to increase nervous system activity, and it's going to activate your system. It's going to make you feel more alert, and it's going to make you feel like you can accomplish more, do more, or you feel really excited. So some examples, amphetamine, nicotine, caffeine, cocaine, all stimulate that system. We're also going to talk about psychedelics and hallucinogenic stimulants, and how they also affect like your perception of what's going on around you, as well as potentially producing hallucinations. So the first thing we're going to talk about is the behavioral stimulants. So here we can see how we're going to start with this. So behavioral stimulants usually increase your motor behavior, and so you might find yourself feeling jittery. You might find yourself kind of wanting to move around a lot. It tends to elevate your mood. It also makes you feel more awake and alert. And what likely happens is that the behavioral stimulants work so quickly that, and you administer them so quickly, and you feel that effect so quickly, which then feeds into this addictive component, because the faster that something can work, then the more likely you're going to want to use that thing, just because it is working quickly. Cocaine is an example of a behavioral stimulant, which comes from the coca plant, and it works by blocking dopamine reuptake. There's a really good video, or interactive video, where I'd like for you to go and check out. It's called Mouse Party, and it kind of helps you understand how cocaine works specifically. So it's just a really good video to watch about how cocaine specifically works. But by blocking dopamine reuptake, we're having more available for the synapses to use. Cocaine can be snorted by being crushed in a powder. It can also be injected intravenously. Since crack can vaporize at low temperatures, people also smoke crack and inhale it. And there are several derivatives. Novocaine, for example, if you ever had like a procedure for your teeth, if you ever had a dental procedure, a lot of times people will get sort of local Novocaine. That is derived from cocaine. And is used as a local anesthetic. And so essentially what it does is it reduces your permeability to sodium, and so it's going to reduce nerve conduction, and so you're not going to be able to feel that area because there's not depolarization happening. So it's just working kind of locally. Other example is amphetamine and methamphetamine. These are synthetic stimulants, and they tend to mimic catecholamine transmitters. So for example, norepinephrine, epinephrine, and dopamine. And so what's really interesting about this group of stimulants is that they will actually cause the release of a neurotransmitter even without using an action potential. So it can potentiate release without causing a depolarization, without causing a full action potential. So it again is a little bit, it's a much more dangerous drug because of the effectiveness of it. And again, mouse party is a really, really great example of how some of these are specifically working. So I do want you to go through it. I want you to do that activity, because then you're going to really see how amphetamines specifically work. And so not only do they work through the absence of action potentials, but they also work by blocking the reuptake of catecholamines into the presynaptic terminal. So it's making more catecholamines available, okay? And it provides an alternative target for the specific enzyme monoamine oxidase, for example, that inactivates catecholamines. So it's basically making sure that the enzyme is busy and it's not breaking down catecholamines. It's blocking reuptake, meaning that there's more available in the cleft and more available to be released, and it's actually releasing more of it in the absence of action potential. So it's working kind of threefold here, which makes it especially dangerous. Now, alertness, euphoria, and stamina, increased stamina, are all some short-term effects of amphetamines, but if you use it over time, you'll see that individuals have a really hard time sleeping, or sleeping a decent amount. They tend to lose weight for many different reasons. It could be that the addiction component is so strong that it actually causes them to only care about the drug and not anything else, including eating and taking care of themselves. We also see general deterioration of their both mental and physical condition. And these, again, are due likely to the person is not, one of it is the drug effect, right? One of it is actually, changing, rewiring and changing their brains, but also it is changing their focus from themselves to this drug. And so if you use amphetamines for a very long time, especially if you use them extensively, what you see is that we actually see this result of looking very much like paranoid schizophrenia. And so what we see is that a person, it's actually really difficult to tell if a person is experiencing a psychotic break due to schizophrenia, or if they are just simply on an amphetamine psychosis. And what we see is this compulsive behavior, agitated behavior, irrational suspiciousness that you see with paranoid schizophrenia. And it gets really hard to sort of tease it apart. But again, a trained clinician should be able to tell the difference, but also we don't want to see this prolonged and chronic use of amphetamines, because then we see this excessive dopamine, happening over time. And of course, methamphetamine especially is neurotoxic. So it's causing brain damage, in some cases, irreversible damage. And with prolonged use, we're seeing it damage both the dopamine and serotonin receptors. So, keeping in mind that these are very important neurotransmitters to a lot of different systems. And if you're permanently damaging or even temporarily damaging them, you're going to affect the person's ability to be able to withdraw from the drug. So if they are actively addicted, that's going to affect their continued use. Now, of course, before amphetamines were used and derivatives were taken, of course, there were some medical uses. So, for example, treatment for asthma, help people focus, to study. Amphetamines in general do improve alertness and productivity, and allows people to spend more time focusing on a particular item. Obviously, we would want to do this in smaller doses. It's also been used as a weight loss aid, because like I said previously, of course, we do have cases where, especially in chronic addiction, where the person is focusing less on eating and more on the drug, but the drug in of itself, amphetamines and methamphetamines, actually do work to reduce cravings for food and the want and motivation to eat. So general stimulants, these are ones that are just sort of generally increasing metabolic activity of your cells. So caffeine is a really, really great example of that. And so one of the mechanisms that caffeine works with is inhibiting that enzyme that normally breaks down the second messenger cyclic AMP. And so when we see an increase in CAMP because that enzyme is broken down, we see that there is an increase in glucose production within the cells, which means that they're able to make more energy, which allows for higher rates of cellular activity. So they're able to be more efficient and do their job more effectively. Another thing, and we've talked about this previously, is that it does block the effect of adenosine. Adenosine is an endogenous neuromodulator. It really helps to put us in a way that we're trying to start to feel drowsy. And so it normally inhibits catecholamine release. And so it's really good to have adenosine, obviously, throughout the day, and especially more toward night, so that we can start to feel sleepy. So it's one of the many chemicals that helps us feel sleepy. But caffeine basically blocks adenosine receptors and keeps us alert. But in response to that, what we typically do is our brains will then respond by making more adenosine receptors, and then you respond to that by consuming more caffeine, and that's how we have to keep that's how we build our tolerance and have to keep adjusting our dose.